So I think the first question is, we now know that after having had COVID, significant percentage of patients develop long-term disorders, and that these disorders, these syndromes can last for months and years and appear to become chronic in significant proportion of them. So there is a post-COVID syndrome with many symptoms that appears to be induced by the infection with COVID. So we have a secondary pandemic following the infection with the SARS-CoV-2 virus that we have now to deal with. And the important point is that this population is very heterogeneous at the clinical level. They have many different symptoms. And what is causing those symptoms, what is underlying the disorders that are long-lasting and that we still see after 3 years in millions of persons worldwide. We need to understand which are the underlying factors that are key to defined clusters, subpopulations of patients that are homogeneous, that can be treated the same way by targeting the same, I would say, cause of their long-lasting troubles. So the project has now gathered many parameters, many biomarkers having been tested in large pilot series which are being analyzed. And we already saw on the first analysis that yes, we differentiate different subgroups with different pathogenic profiles indicated by the biomarkers. And this is very important, because think of how you can treat the patients. If the hypotheses for the long COVID are correct, you have the ones saying that the virus might be persisting. So some studies are trying to treat the patients with antiviral drugs against SARS-CoV. But in those in which the virus is not persisting, it won't do anything. So if you make a clinical trial treating patients in which you only have 30% or 20% of patients relevant for the drug you're giving, you'll never show a significant effect against placebo, and you don't even know if the proportion of relevant and irrelevant patients are the same in the placebo group and the treated group, so it could aggravate the situation. So again, some other patients have some disimmunity and allergic-like phenotypes. Some seem to respond to antihistaminic drugs, but if you give them to all, you conclude that it makes no difference, even if some individuals get better. So again, we are also working mainly in this project on patients who have symptoms that can be induced by the activation of pathogenic endogenous retroviral proteins from dormant genes in our genome. So these are already being identified by validated tests and included in the clinical trial that is ongoing, targeting the HERVW envelope protein, and we will see if the neutralizing antibody shows an improvement on the criteria that we had to choose for the primary endpoint, which will decide whether we can show statistical efficacy or not, because these are the rules for validating a medication and have it on the market. So we are in between fundamental study that can provide answer to major question. What are the factors causing the different symptoms of long COVID, apart from what is aggravating the infection during acute COVID? And secondly, how to treat the patients based on the different categories that we can identify and make homogeneous to treat with a good chance to show that a treatment can be proposed, in which case, and how to know which case is this person or that person. And that is the prerequisite to start treating patients with long COVID, and also preventing severe COVID in patients that are individuals that are still at risk and who will still have troubles with the virus strains that are in the environment today and tomorrow.